In this session on the renal system, we're going to have a little think about glomerular filtration. So in other words, as the blood is coming in through the afferent arteriole, which is shown here, into our capillary network, the glomerulus, and coming out of the efferent arteriole, we get the filtration of this blood into a filtrate coming into the glomerulus and into the proximal tubule itself. So we're thinking about what are the processes that are happening here. So what are driving that glomerular filtration in the first place? And then when we are driving that filtration, how is it actually regulated? How is it regulated at a local level? So we're thinking within the kidney itself, these intrinsic mechanisms that respond really quickly. What hormones are kicking in to help with it? And then autonomically, so thinking about the autonomic nervous system, and then specifically the sympathetic nervous system. So as part of a fight or flight response, that's basically what we're going to be covering today. But first of all, we need to think about what's actually happening. So the capillaries in the glomerulus are actually just like regular capillaries, except they are actually not like regular capillaries. They're much more complex. But the principles of what they do is the same. So here is our regular capillary network. So this can be in our heart, it can be in our lungs, it can be wherever it is. And you've got your arteriole coming in, a capillary coming, so the blood is coming into the capillary, and you have capillary hydrostatic pressure that forces fluid into interstitial fluid, and that's the fluid that bathes our cells. And so water passes through that, and what follows that is your sodiums, your waters, your glucoses, your oxygens, your CO2s, everything that's nice and small. But your cells and your proteins, etc., they aren't being passed through because the pores are too small, the little holes are too small. But as we've got all that fluid moving there, we get a protein buildup down the capillary network, or down the capillary rather, so that you get a higher protein concentration at the venous end of the capillary. And that's how fluid moves back from the interstitial fluid back into the blood. It's that protein pulling force. So the protein is basically pulling the fluid from the interstitial fluid, where there's very little protein, into the capillary network at the venous end. Okay, and that's your oncotic pressure. And in our regular capillaries, excess fluid, about 10%, that doesn't move back through that oncotic pressure, that protein pulling force, goes via a lymphatic system. So that's in essence what is happening. And like I said, we've got the same process in a lot of ways happening at the capillaries in the glomerulus, except it is far more complex, there are more layers and processes involved. So, and that's part of the reason for that, it has much higher pressures. So at the glomerulus itself, you have the hydrostatic pressure is, again, just like in a regular capillary, forces water and small solutes through membrane pores, and proteins or cells are left behind. So it seems similar in that principle. The principle behind it is the same. But it's actually a lot more complex in its setup. And you need to understand this general setup to think about what happens in a variety of different disease states. So the fluid, so here's our glomerulus, our capillary, okay? And the fluid has to pass through this capillary membrane to get into the Bowman's capsule, which is then going to pass the fluid into the proximal tubule, okay? So you've got the proximal tubule running down from there. And so there are three layers. The first layer is you've got this glomerular capillary wall. This is made up of endothelial cells, which you can see, and these little pores allow all solutes to pass, except for cells and platelets and most proteins. So the pores are too small to allow most proteins through there. So it basically is a bit like a fine sieve. You then come to the basement membrane. Okay, so at the level of the basement membrane, this has got a very negative charge, okay, and it's made up of collagen and glycoproteins. And that negative charge repels the proteins that do get through that initial capillary pore. And it repels them because those proteins are negatively charged, your basement membrane is negatively charged, so it basically repels them, a bit like a magnet. Two negatives coming together repel each other. And so it prevents small proteins from passing into that tubular filtrate. So we've got first the pores, we've then got a basement membrane, and finally we've got an inner podocyte filtration slit. And basically this is just another size barrier. Okay, it consists of podocyte epithelial cells, and it's these narrow filtration slits allow fluid leaving the glomerular capillaries to enter the lumen of the Bowman's capsule, and that is your glomerular filtrate. So those are the key things that are actually happening there. But in some renal diseases, this capillary boundary, this capillary wall can start to break down. And so in some renal disease characterized, for example, by excessive albumin secretion in the urine, they can be due to the disruption of this negative membrane, so this basement membrane. So you lose the basement membrane negative charge, which means the glomerular membrane is more permeable to albumin and other proteins, even though the size of the capillary pores remains fairly constant. So that's often why you might see protein in the urine, leading to protein loss. So we now know the three membrane layers that we need to get through at that capillary membrane within the kidneys themselves. And there are also three physical forces involved in the formation of that filtrate, so in glomerular filtration. And these are three forces that are called glomerular capillary hydrostatic pressure. That is, simply put, just the pressure of the blood that is within this capillary network. So blood is coming in through the afferent arteriole and it goes out through the efferent arteriole. And what you can see is the afferent here is wider than the efferent. So that means more blood comes in this way, then it's kind of squeezed in there because there's less space for it to get out. And that creates a nice big pressure gradient. And that's your glomerular capillary hydrostatic pressure. That's about 55 millimeters of mercury, shown on the right-hand side. And that forces the filtrate into the glomerular capsule and then into the proximal tubule. So that's one pressure. That's your main driving pressure. You've also got your plasma oncotic pressure. And just like we talked about in the capillaries earlier, that is your protein pulling force. Now remember, at these capillaries, protein doesn't get through. So there's lots of protein in our capillaries, but not in our filtrate. Therefore, water fluid wants to move back into the capillaries themselves. And that is your oncotic pressure, or your blood colloid osmotic pressure. You'll sometimes see it. And that's 30 millimeters of mercury. The final one is your Bowman's capsule hydrostatic pressure. Remember, this is your Bowman's capsule and there's fluid in it. So therefore the fluid in it is exerting pressure to go the other way, to try and force the fluid back into the capillaries. That is about 15 millimeters of mercury. Okay, so we've now got the three pressures. So if we're looking at those pressures, we've got the promoting filtration one is our glomerular capillary hydrostatic pressure, trying to force the fluid through. And those that oppose are your oncotic pressure, so the amount of protein you got, and the fluid that's already in the Bowman's capsule, so your Bowman's capsule hydrostatic pressure. And so you can also be thinking right now, anything that disrupts any one of those forces can potentially alter the amount of filtrate that forms, therefore altering the glomerular filtration rate. So, for example, changes in your plasma protein levels, so if you have a low level of protein, will alter the oncotic pressure. If you vasoconstrict or vasodilate the arterioles, the afferent arteriole or the efferent arteriole, that will alter the amount of blood coming in and leaving the capillaries, again, altering the glomerular hydrostatic pressure. And likewise, if you have blockages in the ureters or in the tubules, that will cause back pressure, altering the Bowman's capsule hydrostatic pressure. So there are a variety of ways that potential changes in physiology or disease states can alter the driving forces of filtration and therefore alter your glomerular filtration rate. So the first one, as we've already talked about, is your glomerular capillary blood pressure or hydrostatic pressure, and that's 55 millimeters of mercury. And this hydrostatic pressure in here is influenced by your arterial blood pressure and by the vascular tone of the afferent arteriole coming in and the efferent arteriole going out. And when we talk about vascular tone, we just mean how vasodilated or vasoconstricted they might be. And the hydrostatic pressure is much higher than in other capillaries. And that is because of this larger diameter of the afferent arteriole coming in compared to the efferent arteriole going out, meaning that there is a pressure build-up in that place. So in other words, blood dams up in the glomerulus because it can't leave through the efferent. And that's what raises that pressure up to that 55 millimeters of mercury. So, like I said, The summary of this is more blood can enter through the wide afferent arteriole than can lead through the narrower efferent arteriole, which causes that increase in your glomerular capillary pressure, the driving force, or one of the driving forces of glomerular filtration. We then think about plasma oncotic pressure, and that's your protein pulling force, and that's about 30 millimeters of mercury. And that's purely down to the unequal distribution of plasma proteins across the glomerular membrane. Remembering we don't, in health, have proteins passing into our filtrate, so there's none in this filtrate, whereas we've got a decent amount of proteins there, 50, 55 grams per litre within our capillaries, within our blood. So like I said, the plasma proteins can't cross and therefore not present in the filtrate. So water therefore moves by osmosis from a low protein concentration to a high protein concentration to try and make the concentration of protein the same on both sides. So that's just osmosis. It's called colloid osmotic pressure or oncotic pressure, and it's all down to osmosis because of proteins. Finally, we've got our Bowman's capsule hydrostatic pressure. That is purely the pressure exerted by the fluid that is present in this initial part of the tubule within the Bowman's capsule itself. And that is 15 millimeters of mercury. So we're trying to pull the fluid back into the capillaries. So overall, we'll have a glomerular capillary hydrostatic of 55, oncotic of 30, Bowman's capsule of 15, which means our net filtration pressure, if we were to try and measure it, would be 10 millimeters of mercury, forcing or making or stimulating glomerular filtration formation. But when we think about this, our protein concentration and therefore our oncotic pressure isn't actively regulated in terms of kidney function. And likewise, our Bowman's capsule hydrostatic pressure also isn't intrinsically regulated. It's only our capillary hydrostatic pressure that is actively regulated, and it is actively regulated through vasoconstricting and vasodilating the afferent arteriole, the one coming in, and the efferent arteriole, the one coming out. And they are regulated in different ways depending on the condition that the human body, the body experiences, or your physiology is experiencing. So, I want you to have a little bit of a think about this question, and I'm going to give you a couple of questions all the way through. So, suppose this tumour is pressing on and obstructing the right ureter. What effect might this have on the net filtration pressure in the right kidney? So here we go, at the bottom, we've got your net filtration pressure equation, if you want to call it that, which is your glomerular hydrostatic pressure coming this way, so into the glomerulus, minus your oncotic pressure because of protein going in the other direction, minus the Bowman's capsule hydrostatic pressure because of the fluid in the Bowman's capsule forcing fluid to try and go in the opposite direction as well. So what's going to happen? Have a little bit of a think about what will happen to the net filtration pressure and therefore the GFR, or the glomerular filtration pressure, or glomerular filtration rate, better way of putting it. Okay, so hopefully you've had a little bit of a think about this. So we have got a tumour, okay, and it's pressing further down the pathway of the right kidney. So you've got a right ureter obstruction. That will lead to no change in the glomerular hydrostatic pressure. We're not altering vasodilation or vasoconstriction of the afferent and efferent arterioles. We're not altering the amount of protein in our blood. So there's no change in our oncotic pressure, the protein pulling force. But what we are doing is we've got a blockage down here, or squeezing on the ureter, meaning less fluid or urine can pass through the ureter, which means there's a backflow of fluid upwards through the tubules and up into the Bowman's capsule, meaning we have an increase in our Bowman's capsule hydrostatic pressure, which means because this pressure has increased, there is overall a decrease in the net filtration pressure, which means your glomerular filtration rate in the right kidney will reduce. Next question, similar principle. What happens to GFR in a severely burned patient who loses a large quantity of protein-rich plasma-derived fluid? So really what you're thinking here is, This person has got low plasma protein levels. Now, you might get low plasma protein levels from malnutrition, malabsorption, or a variety of other conditions as well. Okay, in this case, we're thinking about someone's lost a lot of protein because of burns. And we're going to presume they are sufficiently, they're normally hydrated. So I want you to think about what happens to the GFR in this case. Okay, so this time we now know they've got a decreased level of protein in the blood. And that leads to a decreased oncotic pressure. So there's less protein here, so therefore there's less protein pulling force. And if there's less protein pulling force, there's an increase in net filtration pressure and therefore a net increase in the glomerular filtration rate. So you make more filtrate.